Okay, good morning. I'm going to get started. We have some front matter and an introduction before our speaker starts out. So we should get going here. So good afternoon, everyone. Happy Valentine's Day to all of you. It's a pleasure, as always, to be here and to be greeting you at the beginning of the afternoon on Wednesdays to bring you another great seminar, continuing on our recent exploration of environmental influences on health. So the Health in the Public Interest Program is a program that emphasizes the non-medical factors that play into health and healthcare. Specifically, we look at things like social determinants of health, environmental influences, influences of pharmaceutical marketing, etc. And it's a one-year MS. We're going to have the URL in chat so that you can see it if you are interested in looking at our website. I want to mention that we have a lot of great seminars coming up over the last 6 or 8 weeks of the program's spring series. And we've had a little bit of instability in the lineup. We still have some of the main people that I've been advertising, but the dates have changed. So bear with us the next couple of weeks as we kind of shuffle and rearrange things. There's been a couple of medical things that have come up and other needs to change dates. So everyone's enthusiastic about giving their seminars, but it's a question of when. And we're going to probably be a little late in announcing next week's seminar, but I think it's going to work out fine, and I think you'll be pleased with how next week's seminars pans out. So with that, let me tell you how this is going to work today. Dr. John Quattrochi from Georgetown University is going to give a seminar on water and sanitation in the Congo. You'll hear more about that in a second. He's going to talk for about 45 minutes, followed by a Q&A session. The moderator today is going to be Kundai Manyara, who's going to be following the chat and helping out during the first 45 minutes, but then being the moderator for the Q&A session, first starting with students and then going into the broader audience. So thanks so much for joining us. And with that, I'll turn it over to Kundai.
Thank you, Dr. Myers. I'm delighted to introduce John Quattrochi today. He is an associate teaching professor in the Georgetown University Graduate School of Arts and Sciences. His research interests include global health and sustainable development, with a focus on interventions to improve the well-being of vulnerable populations affected by fragility, conflict, and violence, particularly in the Democratic Republic of Congo. He has studied cash-like vouchers, water, sanitation and hygiene, social support, empowerment training, health infrastructure, and public work programs. He partners with key international development actors, including the World Bank, United Nations Children's Fund, and Pansy Hospital, whose founder won a Nobel Peace Prize in 2018. His study of a humanitarian assistance program was named one of the top 3 UNICEF-affiliated research projects in the world in 2019. His work has been funded by the National Institutes of Health, Innovations for Poverty Action, the International Initiative for Impact Evaluation, the UK's Foreign, Commonwealth and Development Office, and published in PNAS Nexus, BMG, Global Health and World Development, among other journals. Previously, he was a tenured professor of public health at Simons University. He has a doctorate in global health and population from Harvard University and a bachelor's in economics from the University of Pennsylvania. He was also a Fulbright scholar in Entebbe, Uganda, and a Rotary Ambassadorial Scholar in Naples, Italy. He is also a participant observer in a longitudinal study on fecal oral transmission with a sample size of 2, his almost 2-year-old and his almost 5-year-old. Dr. Quattrochi.
Thank you, Kundai, for that generous introduction. I thought it might be fun to start us with a poll. If Elizabeth, if you don't mind launching that, this is going to ask you to get us in the mood and in the right mindset to take in some information. Which of the following medical milestones do you think was most important? Looking back to, I think all of these are since 1840, if I remember correctly. So your vote is anonymous, no pressure, but if you take a look at this list, there's 15 things on the list, I think. Which of these would you say is most important? And maybe while we give folks another 30 seconds or so to answer, I will start sharing my screen. What do you think, Elizabeth? If there are no more answers trickling in, we can probably take a look at the results. Oh, all right. We have a sanitation-friendly audience. Perhaps the title of this talk may have swayed. We might have some social desirability bias in the responses to this survey question, but I'm very happy to see sanitation as the most common response here. That's the same answer. This poll was done by the British Medical Journal in 2007 of its readership, and sanitation also came out on top on that poll. And I'll show you those results in a minute, but I think it speaks to how long we've known about how important sanitation is, and then how long we've known about that. That's since the 2007 poll. I'm sure it was recognized before that. And that, when the British Medical Journal made this poll, they were really talking about work by Chadwick and others in 1840s London about the importance of continuous piped water into the home and sewage rinsed by water. And we're a long way from universal access to that, and that's a lot of what I'll talk about today. But first, let me just mention before I forget, thank you for your participation, and thank you for the invitation to the Happy program. It's really nice to have this opportunity to share my work. And this, it's not just my work, it's work with my colleagues. You can see on the screen here, hopefully, Aidan Coville at the World Bank, Kevin Croak at Harvard, and Eric Mbukiehe at Duke. A lot of other people are involved in this project, but these are the principal investigators here. So I'm going to talk about the health impacts of DRCongo's National Rural Water and Sanitation Program, but I want to spend a little bit more time on some background yes. So here are the results of that BMJ survey, sanitation coming out on top. We are in good company. But we're far from universal access. A lot of people around the world are still using what we might call unimproved sources of water and sanitation. So on the left here, you see an unprotected spring, which would be considered an unimproved source. A protected spring on the right might be considered an improved source, but even the water quality from something like that might not be as high as we would like to see. In terms of sanitation, when we talk about unimproved sources, might be something like the basic pit latrine you see on the left. An improved pit latrine on the right might have a concrete slab, a concrete cover, and just a cleaner area to defecate in. So I said millions of people are still using these kind of unimproved sources. Let me be more specific here. This figure, there's a lot going on here, but this is showing you how far we are from reaching the Sustainable Development Goals in terms of drinking water, sanitation, and hygiene. From 2015 to 2030, this is showing the progress from 2015 to 2020, and then what it looks like if that continues to 2030, and then how much we would need to improve to reach the SDG of universal access. So for drinking water here, for example, only 70% of the world had access to safely managed drinking water in 2015. That increased to 74% in 2020. And if that pace continues, that only results in 81% by 2030. We would need to accelerate progress by 4x, by 4 times, if we want to reach universal access in drinking water. And you can see for sanitation, there's a few different levels of quality shown here, but for all of them, we need to accelerate by 1 to 4 times. And for hygiene, in terms of access to water and soap to wash hands, we need to accelerate progress by 4x to reach the SDG. And the situation is significantly more dire in sub-Saharan Africa. So now same figures, but shown for Africa alone. And you can see we need to accelerate progress by 4 times for basic drinking water, up to 42 times for hygiene, where there's just been very little progress made. By the way, I forgot to mention, please feel free to interrupt at any point in the presentation. We're not that big of a group, so I'm happy to take questions either in the chat or if you just want to unmute and ask a question, totally fine with that.
Okay, I have a question.
Yes.
Recent WHO report noted a major increase in cholera, and I felt a little dismayed that the media coverage noted a lack of cholera vaccine rather than a lack of clean drinking water. What do you think about the increased rates and how to deal with it?
Yeah, that's interesting. I'm guessing they're trying to play on the, all the attention around the COVID vaccine. Maybe people are more interested in reading about vaccines than old-fashioned toilets and tap water. But I mean, I'm going to talk about in a second. There are so many, we have so many tools that we can use to improve water sanitation and hygiene. It's almost, it becomes a challenge scientifically. And perhaps in terms of maintaining people's attention as well. But I think we should be using everything we can to reduce diseases like cholera, which really should be, that should no longer be an issue in 2024. Yeah, thanks. Any other questions at the moment? I mean, I'll just say again, please, thank you for jumping in and jump in more as you would like. So I'm showing higher gaps in Africa in terms of reaching these targets for water sanitation and hygiene services. The consequences of that are shown here. I know there's a lot going on in this table, but bear with me for a second. So on the left, the leading causes of disability-adjusted life years lost in 1990. So what causes the most disease and death in the world in 1990? Neonatal disorders, number 1. Diarrheal diseases, number 3. In 2019 on the right, a little bit of change, but still diarrheal diseases are number 5 in terms of causes of the global burden of disease. And much of that is due to inadequate water sanitation and hygiene. And as you might guess from what we saw before, the burden of diarrhea is geographically concentrated in Africa. The top map here shows diarrhea mortality rate across all ages. The bottom maps are showing specifically in children under 5. And if you look at country by country, the 40 countries with the highest under 5 mortality due to diarrhea, 35 of them are in Africa, and the other 5 are listed here in the lower right. So further consequences of not having adequate wash. Over 800,000 deaths per year. Children who survive often suffer from linear growth failure. They're not as tall or as long as they would be in the absence of chronic enteric disease and dysfunction. And that in turn has been linked to reduced cognitive development and reduced wages when people are working, so there are economic consequences as well. Furthermore, all of this water that needs to be collected from distant sources creates a time burden, and that falls disproportionately on women and girls. And all of these problems are most severe in rural areas of low-income countries. So what can we do about it? What's being done to address inadequate water sanitation and hygiene? I like to divide interventions into demand side, supply side, and demand and supply side. So demand side interventions, we're targeting the people we want to see using more water sanitation and hygiene. These could be behavior change campaigns. like community-led total sanitation, which tries to use really the idea of disgust to convince people not to defecate in the open. There can be pricing reforms, like decreasing the price of water, legal reforms like making open defecation illegal. And then on the supply side, there are all sorts of gadgets and gizmos that have been invented to try to clean water cheaply, different types of filters. Then there are more traditional tools like boreholes and latrines that can be provided free by governments or by NGOs. Privatization or nationalization of service delivery is another option to try to change the supply of water and sanitation services. And then there are some interventions that target the demand and the supply side, like decentralization of who's responsible, for example, by creating water use associations, even at the village level, so that villages are more responsible for their own water and sanitation, which has pros and cons. So one problem, when you think about all of these different things that we could do for WASH, many programs combine one or more of these. So if you think about the design space of all the possible, there are just many, many different things we could do to try to improve WASH. And that creates a challenge scientifically, because there are just many, many studies we would need to do to understand the relative effectiveness of all of these. And because we're in a world where we are trying to increase water and sanitation as cheaply as possible, there's a lot of work to try to get at the exact cost effectiveness of different combinations here. So that's why you can have something like this. Here's an evidence and gap map that was done in 2021 that identified 367 impact evaluations in low and middle income countries trying to increase water, sanitation, and hygiene use. And even with 367 studies identified, they concluded that the evidence base probably remains too small to draw conclusions. It's just that there are all of these combinations, and even 367 studies is just not covering enough of them. So that's why I'm arguing that number 368, which I'm going to present to you now, is a valuable contribution for a few reasons. So what I'm going to talk about, the program in Congo that I'm going to describe, it might be a unique combination of water and sanitation infrastructure, mostly spring improvements and latrine improvements, that's done in coordination with the community, a behavior change campaign to try to get people to use that infrastructure and increase hand washing, and then new institutions, specifically water management committees at the village level. This is something that was done nationwide in a country, DRC, with low water and sanitation services to begin with. Much of the country is affected by armed conflict. I'm going to show you results from 3 years after the program ended to see if any changes persisted. And we have an objective measure of health, which is children's length for age, related back to that issue of stunting that I mentioned before. So here's just a little bit more on DRC. Even within Africa, Congo is in the lower half of access to improved water. About 52% of the population has access to improved water, and 29% has access to improved sanitation. DRC has about 100 million people. It's projected to be 250 million people by the end of the century, in which point it will be the 5th largest country in the world. And it has the 5th lowest income per person in the world currently. So a very important population from the perspective of health equity. What DRC did back in 2008 is create this program called Healthy Villages and Healthy Schools. This is the program that we're going to be studying, that we studied. This was a collaboration between the Ministry of Public Health, the Ministry of Education, in partnership with the UN Children's Agency, UNICEF, and then implemented by at least 100 NGOs across the country. It was financed largely by the British Foreign Aid Agency at a cost of about $30 million a year, which is peanuts. It's probably what Georgetown spends on special events in a year, but this is to provide water and sanitation to 50 million people. About half of DRC is rural. This program succeeded in the sense that it reached 6.5 million people across thousands of villages since 2008. And here's how the program worked. So that's what this diagram is trying to show. It's a community-led program in the sense that step 0, the community decision, the community, somebody, typically the village chief, should agree with a representative of the state health authority to participate in this program. They agree on the mutual commitment in step 1 there. Then an initial assessment is done where the medical officer from representing the state with the villagers decides what the problems are, discusses how water and sanitation can create problems in terms of health, and what can be done about that. So that's the initial assessment, the participatory analysis, step 3. Step 4 is when the local WASH committee is created that will be in charge of efforts to improve access to water and sanitation and hygiene. Step 5, the village, in partnership with the state, creates a plan of how they want to make some improvements in WASH. Step 6, community-based action. The program actually provides about $4,000 per village for things like spring protection and latrine improvement. Step 7, there's an assessment done after the infrastructure is built to see if it's being used, if people's behavior has changed. And there are these 7 norms, things like, is 80% of the village washing hands? If those norms are met, then the village is certified as a healthy village. And there's the thought that maybe by making that public, there's some positive competition with other villages. So what we're going to do in this study is simply compare villages that did this program to villages that didn't do this program. We randomly assign villages to either receive this program or wait to receive this program at a later date. And here I just have a few pictures. This is a picture of one of these community meetings. So you can see there are some pictures in the background about hygiene, and there's a discussion about what the challenges in the community are. This is one of the water management committees that will be in charge of making sure that water points are functional. If the community decides to collect fees, this is the committee that would typically do that. Most of them do not. But that's one example of a WASH committee. Here's a map of DRC showing all of the gray territories are places where this program has been operational. For the study, we did not have a budget to work in that many areas, so we are working in the 4 colored in provinces that you see here, and the yellow dots are control villages and the red squares are treatment villages. So again, we're randomly assigning villages to either receive the program or wait and receive the program when the study is over. We started talking about this study back in 2017. March 2018 was the impact evaluation workshop with partners in country. Randomization was done back in June 2018. Program implementation took us through August 2019. And then I'll just skip ahead. The last survey that we did to go and visit households and measure children and talk about their water and sanitation situation was done in November 2022 to April 2023. So those are the 3.5 years post implementation results that I'm going to show you. And the study design is pretty simple. So we had 332 villages that UNICEF and the government identified as being eligible for the program. We were worried about spillover effects, so we didn't want the program in one village to benefit a neighboring village, that we wouldn't want a control village to be too close to a treatment village such that the treatment is affecting the control village. So we group villages into 121 clusters. So each cluster is at least 2.5 kilometers away from the nearest cluster. It's those 121 clusters that we randomly allocate to either be in the program group, those 50 clusters on the left, or the control group, the 71 clusters on the right. And then in each cluster, we went and talked to 5 households at the midline survey, which is in 2019, and 10 households in the 3.5-year follow-up, which we did in 2023. And we had pretty good luck finding households 3.5 years later. That can be an issue, particularly in populations like the DRC where there's a lot of displacement. But you can see in the table here, close to 90% on the bottom, in close to 90% of households, we found the same respondent at midline, which was 5 months post-implementation, and at 3.5 years after. So we don't think loss to follow-up or attrition is a big concern in this study. One reason why doing research in Congo is challenging is that most roads, even pretty major roads, look like this for at least part of the year. I've been to a number of low-income countries. They all have problems with roads, but Congo is really in another league. It's actually impossible to drive from one side of the country to the other. You have to fly. So big kudos to our data collection teams for dealing with challenges like this. All right, the first thing you want to do with a randomized control trial is check to see that on characteristics of your study participants, they're more or less similar in your treatment group and in your control group. So treatment group here, intervention group, that's synonymous for that's the group that got the program. Control group did not. So you can see there's some difference on improved roof. So 27% of the control group had improved roofs, like a tin roof, versus 37% in the treatment group. But for most of these characteristics, there's not much difference, which suggests that randomization was successful. The other thing you can learn from this table is just what the socioeconomic status of this population is to some extent. So about 30% of respondents have completed primary school, and about 5% have completed secondary school. And everyone else would have completed less than primary school. Another good thing to do with the randomized control trial is to see if the treatment was actually done. Did the villages that were assigned to the program, did they actually receive the program? So this figure is showing those 8 steps that are the program steps, and what percent of villages in our treatment group had completed that step by 5 months after program implementation was supposed to have finished. And we have pretty high implementation rates until you get down to step 6, implementation of the action plan. Only 78% of villages had completed that at that point. And then only 56% had actually had the end-line evaluation by the health zone, which is the state health representative, and only 35% were certified as a healthy village. So some lack of compliance here. Nonetheless, I'll show you, these are the outcomes at 5 months after implementation, the short run results. You can see we had 4 primary outcomes. In terms of time to collect water, there was no difference, no statistically significant difference between control and program villages. And in terms of quantity of water collected, there was no difference. But we did find a pretty large difference in terms of access to an improved water source. 33% more of the program group households reported that they used an improved water source, and 26% more of the program households reported using an improved sanitation source. So this is, again, at 5 months. So we had a question, did this persist to 3.5 years? And did that result in any benefits to health, which is really what we care about at the end of the day. We also measured some secondary outcomes at 5 months, and I have circled the ones that show statistically significant effects here. All of these are standardized effects in terms of standard deviations. So we saw improvements in water governance. This is really due to the presence of those water or WASH committees. Improvements in reports of satisfaction with water. Improvements in terms of sanitation practices. That's driven by people reporting less open defecation, less pooping in the open, in other words. And then people are reporting more hand washing, although I'm going to asterisk that because that's self-reported hand washing, which is notoriously over-reported, and we actually observed hand washing behavior in the end line. Okay, so now moving to the 3.5-year results. This is I'm showing you the same figure from 5 months, checking adherence was the program implemented. At 3.5 years, there is some improvement, right? So we've gone from 78% implementing the action plan in step 6 up to 86%. 71% have done the end-line evaluation. Still only 53% are certified as a healthy village. So keep that in mind as we see these results of 3.5 years. So this is, if I could only show you one slide for this entire study, this would be that slide. These are the results for our 3 primary outcomes at 3.5 years. The first, and this is in terms of the treatment effect. So what's the difference taking the rate in the program group, subtracting out the control group? So in terms of caregivers' reports of children's diarrhea, if we ask typically mothers, did your child have diarrhea in the last week or 2? We see a very precise 0 in terms of a difference between program villages and control villages. That's disappointing. No benefit in terms of diarrhea. Length for age, that's where we physically measured each child and compared how long, if they're laying down, or tall they were to the WHO reference standard. And again, we see no statistically significant difference between program villages and control villages. Again, that's disappointing. No health benefits from the program. Then our third primary outcome was a WASH institutions index. So did the WASH committee persist, and was it doing anything? And we did find that in the treatment villages, they score about 0.37 standard deviations higher on this index. And what that really means is that many more of them still had a WASH committee, even 3.5 years later. And I think I have the exact numbers on that here. So a lot going on in this table, but the first, we have diarrhea, length for age, WASH institutions index. So same 3 variables that you just saw in the figure. Now I'm giving you the number of observations, the mean of that variable in the control group, in the treatment group, the intention to treat effect, comparing the treatment, taking the treatment value and subtracting the control value, and then a 95% confidence interval for that treatment effect. So again, no effect on diarrhea, no effect on length for age, and a beneficial effect in terms of WASH institutions. Another thing we learned by looking at the table is that diarrhea rates are quite high. So 40% of mothers are reporting that their child had diarrhea in the last week or 2. And in terms of length for age, these are Z-scores. So the average child in this population is more than 2 standard deviations smaller than the WHO reference standard. So that suggests and is consistent with the diarrhea that there are chronic enteric disorder, dysfunction in this, that there's a high burden of fecal oral transmission of disease in this population. The bottom part of the table is showing you the components of this WASH institutions index. And there you can see that it's really that first question that's driving the positive result. Is there a committee, a WASH committee in this village? Yes or no? In control villages, 69% say yes, there is a committee. In treatment villages, 99% say yes, there is such a committee. We also see that in treatment villages, those committees are more likely to say that they track the health of the village. Moving on to secondary outcomes at 3.5 years. Let's take our time here. There's a lot going on. So the first 2, improved water source and improved sanitation facility. This suggests, in both cases, we see positive results. So 24% more households in program villages have an improved water source. 18% more households in program villages have an improved sanitation facility. So those improvements we saw at 5 months mostly persisted to 3.5 years. It wasn't sufficient to improve health, but at least there are improvements in these sources and facilities. The next outcome is governance perception index. We asked respondents how they felt about the governance of water in their village, and in treatment villages, people report more positive perceptions of how water is governed in their village. The next variable, the next outcome, is the water point working? So this struck us as bizarre at first. In program villages, the water point is less likely to be working than in control villages. But the explanation here seems to be that in control villages, you're much more likely to have an unprotected spring or people using surface water from a river or a lake, and those sources can't break. So I think it's maybe not surprising that once you have a slightly more technologically sophisticated source, it's less likely to be working. It can break. The next two outcomes here, weight for age and weight for length, those are other anthropomorphic measures about children's sizes. And on those as well, we don't see any change, any difference between program and control villages. The next two outcomes are on hand washing. This is what I was alluding to earlier. In terms of self-reported hand washing, if you ask people if they washed their hands yesterday, people in program villages are much more likely to say yes. But we also asked our research assistants to spend 2.5 hours in each household observing if hand washing was done at critical junctures, such as before eating or after changing a baby's diaper, or cleaning a baby after defecation. And in terms of observed behavior, we found no difference in hand washing between treatment and control villages. That's that hand washing action variable. And also, if we just restrict the variable to hand washing with soap, so not hand washing with water doesn't count, but only hand washing with soap, again, we see no difference. The last two outcomes here, we were curious if there are psychological benefits or benefits in terms of life satisfaction and self-esteem from having improved water and sanitation. And the psychological well-being index shows no statistically significant difference. The life satisfaction and self-esteem index is just barely statistically significant, showing a benefit from improved water and sanitation. So that's a lot of results, but we had our 3 primary outcomes and then many secondary outcomes. And I think the picture that emerges is we're disappointed that there are not health gains despite these improvements to infrastructure. So we wanted to dig into that a little bit more. Is it that the water quality has not improved in these sources? Is it that people are not actually using the improved sources? Or maybe it's about water quantity and not quality. And for the first question here, we actually have quite a strong answer because we sampled water at each water point and in each household. And so I'm just showing you for the sake of time at each water point. We took a sample and we measured how much E. coli, how many thermotolerant coliforms are in that sample of water. And the axis here on the horizontal axis is showing you how much E. coli, where less E. coli is better. So we want everyone to be in that under 1 category. Unfortunately, almost all of the water points are in that over 100 category, which is considered very high risk. And the treatment group is in black here, the control group is in pink, but the dark red is where they overlap. So there's almost no difference between treatment and control in terms of water quality. And what's perhaps even more shocking, if I can get to the next slide, this is showing the same thing, but now by type of water source. So piped public tap, protected spring, unprotected spring, surface water. For each of those sources of water, what percent of those are in each risk category, with gray being the highest risk. And you can see even for the improved sources, the piped and public tap, the protected spring, what we think about as improved sources, still 60 to 65% of the water samples were registering as very high risk. So it's an improvement on the unprotected sources where you're getting 80 to 90% as very high risk, but it's not much of an improvement. And unsurprisingly, if the water is contaminated at the source, it's not going to become cleaner at the household. So the household level data looks very similar to the source level data. Another issue that arose is that people are spending a lot of time in their fields. Most people are farmers in these populations. And when they're in their fields, when they're farming, they don't have access to the improved sources that are built near their home. So in both the treatment and control group, close to 60% of people are using surface water from a lake or a river or a pond as their primary drinking water. So that's going to be very high risk. And 94% of respondents who spent some time in the fields reported that they engaged in open defecation there, which makes sense. It's rare for a latrine to be built in fields. So to conclude, I know we have some time left, but this is good. We'll have more time to discuss. We find that this complicated program was successful in improving infrastructure and institutions. And I think, this is in a very low income setting with armed conflict near to some of these villages. So the fact that something was able to be done in terms of improving infrastructure, I think is a real achievement. And it was done at very low cost for $7,000 per village on average. But there was no effect on health. So we need, if we want to improve health, the program needs to do more. And it seems like water quality is the reason why there was no benefit to health. But the program also did not improve water quantity. People don't report using any more water. And there are some other studies that show water quantity may be equally important to water quality in terms of lowering rates of diarrheal illness. So I will just on this last slide say thanks to our partners in the DRC government, the British Foreign Aid Agency who funded this, our partners at UNICEF, the World Bank's Development Impact Evaluation Group is the lead research organization on this. And we have some excellent colleagues there who have helped with some of the analysis. And then the data collection was done by the Innovative Hub for Research in Africa, which I highly recommend if you need to do a household survey pretty much anywhere in Africa. But I will leave it there and welcome any questions or comments.
So thank you, John. Let me just pose a couple of quick questions while Kunde gets ready to take some from the students. So I was wondering, one thing is, what kind of approvals, like IRB kind of things, do you need to get for doing this kind of research? You talked a lot about research methodology and everything else. If you did this here, I think you need to be, you'd be overwhelmed by the amount of requirements for IRBs, et cetera.
I mean, we had to get ethical approval from a Congolese partner institution. So I've been working with the Catholic University of Bukavu for some time. So we went through their ethical committee, and then we also went through an American IRB. The World Bank, surprisingly or not surprisingly, doesn't have its in-house IRB. So we used a company called Solutions IRB. So we had to go through, 2 different IRB processes. And this had to be approved by UNICEF, by the government, and by the UK's Foreign Aid Agency. So it was pretty rigorous ethical oversight there.
Okay, thank you. Kunde?
Thank you so much for your presentation. I will start with any happy students. If you have any questions, please raise your hand and I'll call upon you. But if not, I'll start off with a question of my own. I saw the picture of, the roads in Congo, and I know where Congo sits. It sits on the equator, and you have a lot of rain. Aside from the difficulties that the climate gave you, because I think that's why the roads are so inaccessible most of the time, were there any advantages to being in a place where you're trying to create a sanitation program and you have so much water coming in? Were there other methods or implementations in order to improve water quality that were directly related to the amount of rainfall that they receive each year?
Yeah, that's a great question because, I mean, in part because this is not a situation like the Sahel of Africa in a country like Mali where there simply isn't enough water. This is a water-rich country. It's most of it is rainforest. It's the second largest rainforest in the world after the Amazon. So, yeah, it's not water scarcity in most parts of the country is not the issue. It's really the water quality. So, you know, I think that's why that I guess the benefit of that was if since so many of these springs exist, it's not that expensive to protect a spring to build some cement around it rather than having to drill a new borehole that like you might have to do in a country with less water. The downside is that what we're seeing is that if you protect a spring, the water quality can still be quite low. So that's simply not enough. But yeah, I mean, in other parts of the Congo, especially in more urbanized areas, there are gravity-fed water systems that might serve a small city, and that that is not an option in places where water is really scarce. So there are a lot of opportunities in DRC. It's just we need to figure out ways to increase that water quality.
So I have a question about it's about the protected spring. Is it just putting concrete around it? I mean, making a spring less muddy doesn't make it less bacterially contaminated. Were there any efforts made to actually say prevent open defecation anywhere near the spring? Because open defecation in a field really doesn't make any difference. It's really how close is open defecation to a water source. Were there any efforts made to connect the spring's water source to, you know, a higher elevation, or is protection really just concrete around it so it's less muddy?
Yeah, so part of the community process of identifying challenges and developing a plan to address them involves talking about the process of fecal oral transmission. So that would include, you know, if somebody defecates near a spring and that gets into the water, that's going to get into our bodies and cause disease. So following from that, the idea is that open defecation stops everywhere, but I assume there would be some emphasis on defecating near springs. Then in terms of spring protection, the part of the improvement is putting a pipe in so that the water comes from a little bit lower, which, you know, in some areas would increase quality, but I guess because there's so much runoff, I mean, this is an open question, but because there's so much runoff from humans and animals, I think there's some groundwater contamination in these areas, and that's why the protection is not sufficient.
There's a question in the chat from I do not want to mispronounce this name, but it says, thanks for this brilliant presentation. Your results confirm what we have seen in Western DRC, where we are conducting research on schistosomiasis since 2000.
Schistosomiasis.
Thank you. 2009. My question is about the variability of water quality outcomes between provinces, given the variability of ecosystem in Congo.
Thanks, Jewel, for the question. And that's a great one that we haven't yet looked into. We did work across 4 provinces, but we have our sample size is not, we don't, what you can do a lot of different statistical tests once you have a data set. And if you do enough, you will find differences, but we don't think we have adequate statistical power to really say anything conclusive about differences across provinces. So I'm happy to share the results that we have. If you can send me an email, I'll put my email into the chat right now. But I would be very hesitant about interpreting them as, you know, we don't have a representative sample of each province, so we can't really talk about how the water quality in South Kivu compares to the water quality in Congo Central. We just know what's in our study population. I think UNICEF has done systematic water quality testing, and if I can if I can find that, I'll send it to you.
Thank you. Any questions from any happy students?
Fine.
Yes, Emily. And then Jasmine, sorry.
Yeah, thank you. Thank you so much for this great presentation. It was really interesting. What was the experience like when it came to educating people into these like new routines? Or it sounds like part of the problem was like you can offer like a safe space for the water and where it will be clear, but then you also kind of have to counteract like behaviors when they're going to work or working in fields and things like that. So did you glean any interesting insights about like preconceived notions they had or like barriers that you didn't expect when you were talking to these groups of people?
You know, I think I'm trying to, so my sense is that people have a pretty good understanding already about the need to wash hands and avoid fecal contamination. We did ask people about knowledge around hand washing, and I don't think we saw a difference between treatment and control, but I don't know what the levels were like.
Mm-hmm.
I think it's really about people need more resources. You know, continuous piped water into the home makes it very easy to wash hands. If you still have to walk 15 minutes and there's no soap once you get there, it's just, you know, no amount of education is going to help with that. So I'm skeptical that awareness or education is really the constraint here. I think it's about material resources.
Yeah. Thank you. That's really helpful. It's interesting how sometimes we always go to education and then sometimes it's actually just accessibility when you think about like the amount of time it takes to do something. So thank you. Really helpful.
Yeah.
Jasmine.
Yeah, thanks so much for your presentation. So I was just, I guess along the same lines as Emily, and you might have answered this inadvertently, but what's the biggest challenge in getting the community? What was the biggest challenge that you saw in getting the community involved and engaged?
Yeah, I don't, you know, so we're working in 332 villages. Each village had its own process of somebody from the Congolese health system coming to the village, meeting with the chief, getting the community together, and then developing a plan. So, and I wasn't there for any of that process. So I don't, you know, from anecdotally from talking to our partners in the Congolese health system, there were no big issues there. I think people are, in general, you know, generalizing here, I think these villages appreciate any help from the state because in large part, the Congolese state is absent. It's not doing much, particularly in rural areas. So if somebody comes and wants to help and says they're going to build some water sources in the latrines, I don't think it's hard to get people to buy into that process. Again, it's not enough is being done to improve the infrastructure.
We have a question in the chat from Nehemiah, and it is, I would like to know if this project took into account the perception of population of this project in the treatment group.
Yeah, I think that the best measure we have is we asked people in both the treatment and the control groups, essentially, are you satisfied with how water resources are managed in your community? And there we found that people in the treatment group were more likely to say that they were satisfied with how water was managed in their community. So I think that's not about the perception of the research project, but the perception of the program that we were studying seems to be quite positive.
Margot?
Hi, thanks for coming and sharing your research with us today. I was just wondering, as you all were reflecting on the results of the primary outcomes, if you all considered any factors that were non-sanitation related that could have impacted the results. I'm just thinking of things like nutrition that, you know, are factors in like stunted growth for children. So just wondering about any other factors that were considered.
Yeah, that's a great question. Yeah, access to adequate nutrition would be a major determinant of child growth, of stunting. The power of a randomized design is that, in theory, because we're randomly assigning villages to one group or the other, on average in both groups, the program group and the control group, nutrition should be the same. So any challenges, you know, if there's inadequate rainfall in 10% of the villages, those 10% of villages should be balanced between the treatment group and the control group. So we are relying on random assignment to control for those kind of factors, but they're certainly important. And we didn't ask to do a proper survey module about what people eat. Takes a long time because there are so many possible foods. And so we're always trying to be aware that we're taking people's time in these surveys, and we only want to ask about what's essential. So we didn't include a nutrition module.
And Rihanna.
Hi, thank you for sharing your research today. So I may have missed this at the beginning because I was having some technical difficulties, but I'm curious about your like personal journey that brought you to this line of work. But yeah, I mean, I'm pretty interested in global health myself, and I think it would be insightful to know about your like academic and career journey that brought you to this point.
Yeah, I'll give you the really short version is 2 books in my early 20s really blew my mind. One was The End of Poverty by Jeffrey Sachs, and the other was Mountains Beyond Mountains by Tracy Kidder. And that got me interested in these huge inequalities in life expectancy driven by child mortality across the world. And DRC is, you know, at the bottom of the ladder, so to speak. And it's quite an understudied country because it's Francophone and because of all the armed conflicts. So that's why I was interested in working there. And then through some colleagues at the World Bank got linked up to this particular study. That's the short. Happy to talk about the long version some other time, but that's the short version. I see a question about access to non-water hand sanitizers. We did not provide, the program did not provide those. Those are not super common in Congo, and I think they're relatively expensive, particularly in comparison to chlorine, which is really what's now being considered essential for programs like this. So even in Congo already, they've started to add chlorination to all of their wash programs. So that could be just, you know, a drip of chlorine at the water source when you fill up your jerry can. And that's really where the research and practice seems to be going, is how can we ensure that there's a steady supply of chlorine at water sources to treat water and improve, you know, and kill pathogens in the water right at the point of collection.
So while we wait for the larger audience questions, I have a quick comment, John, which is that I think the real value of your study is that I think it leads the way to evaluating what does need to be done before you start seeing remarkable improvements in the parameters you're measuring, and what are some of the things that are responsible for the negative results in some area, that those are just as important as finding big improvements, right? For $7,000 a village, you know, that's a really worthwhile thing to know and to address in further work. So another editorial comment that I just throw out there in case it stimulates any discussion anywhere is that, you know, even in this country, we don't look at water and sanitation as a basic human right. When I moved to Montgomery County in the late 1950s, as a child, I went to school with kids who didn't have water or sanitation beyond like an outhouse behind homes which were built in the post-Civil War era for freed slaves. And those communities in Montgomery County, Maryland, didn't disappear in that form until at least 1970, right? And then if you look out west, you have the indigenous peoples nations like the Navajo Nation, where water and sanitation are huge issues. I really think we ought to think about water and sanitation as a basic human right, and look at it as a higher priority. You know, healthcare, great, you know, but before healthcare, we need sanitation and we need water. So I just throw that out there.
I couldn't agree more. And the Flint water crisis is another example of how this plays out in the United States.
Yeah, absolutely. We had the principal person who brought that to the attention of the press on a seminar a couple of years ago, and that's a great example, John.
I do see another question in the chat from Jules about the low percentage of villages that were declared as healthy. So he's referencing there was this, at the end of the program, a village can be certified as a healthy village or not based on 7 norms that I didn't show you. I don't want to put the way those norms are assessed is somebody from the state health authority comes to the village and they do a quick survey-ish exercise based on a convenience sample. So, you know, it's a, how shall I say, it's a quick form of data collection that doesn't really rely on representative sampling, and it relies on a lot of self-reported data. So I don't know that, you know, a village being certified as healthy has a really strong correlation to health outcomes at all. So we're not really, we're not really focused on that in this study so much, but it is, you know, I guess it would still be good to know if they are not being certified because they're not meeting the norms, or maybe because the state health agents are just not taking the time to go back.
Are there any questions?
So anyone from the larger audience, you're welcome to unmute and speak up. If we don't hear anything, we're going to end a little bit early today, which is not a reflection on the quality of the presentation or audience today, but maybe, you know, we've had quite a bit of discussion and thought as we went through this. Okay, so not hearing anything, I'm going to call an end to the seminar. I want to thank John for really a great presentation, something that I think brought some experimental and scientific thinking to public health issues that we don't usually see applied in a seminar series and need more of. And welcome to Georgetown, John. You're a relatively new faculty member, and look forward to having you back one day. And so I urge everyone to watch for the seminar announcement for next week, a little bit later than usual. We're still working out a couple of kinks, and we expect to go ahead on our weekly seminar series as scheduled, but with some changes in who's speaking. And thanks so much, everyone, for being here. Thanks, Kundai, for a great job moderating, and Elizabeth, thanks for everything that you do in the background, including presenting the quiz at the poll at the beginning today.
Thanks again for the invite. This was
okay. So we'll send you